Maria is a 23-year-old Caucasian female who presents with a chief complaint of having episodic panic attacks in her sleep. In the last 2 months, she has been seen in the emergency room 4 times for acute feelings of having a heart attack. Her last episode occurred at work, where her coworkers had called an ambulance for her. Her episodes consist of acute sudden onset of intense chest pain, palpitations, and shortness of breath, as well as sweating, trembling, and the fear that she is about to die, which peaks within minutes. This has been affecting her quality of life and interfering with work and social relationships. After conducting a comprehensive psychiatric review of systems and a 12-point review of systems, and with no history of psychiatric disorders besides subjective social anxiety, Maria does meet criteria for a panic disorder related to her physiological symptoms she's experiencing with her episodes, and it is unrelated to being a specifier. She is most likely also experiencing post-traumatic stress disorder as it relates to the exposure to her mother's traumatic death by suicide and her grandfather's recent passing. Her treatment plan includes starting sertraline 25 milligrams for the first 3 to 7 days, and as Maria tolerates this, it can be titrated up from 25 to 50 milligrams per day. Her clonazepam initial dosing will be 0.5 milligrams per day in 2 divided doses, and this is going to be as needed for her panic attacks. Pertinent to mention that Maria does not have a history of substance use disorder, which is something to be mindful of when prescribing benzodiazepines. And also SSRIs for this particular disorder should be started at a lower dose rather than the dose that's typical for depression, because it can be potentially activating or overstimulating, and then it can gradually be increased as tolerance progresses. Sertraline can activate hypomania or mania, and there is also an increased risk for bleeding with the use of NSAIDs. Hyponatremia is also a rare but serious concern to be monitoring for, especially in high-risk populations. There's also a risk for serotonin syndrome, and signs and symptoms should be monitored for, as well as a suicidal ideation related to Maria being under the age of 25. Although it is rare, it does occur and can be fatal, so a safety plan should be in place and be discussed with Maria. Discontinuation syndrome can occur if the medication is abruptly stopped, and so Maria should not do this without having a conversation before she decides to do that. And there's an increased risk for sexual dysfunction with SSRIs, and if this is problematic for Maria, then we can have a conversation about maybe switching to another drug. And sertraline does pass through the placenta, so it's important to note that if she does become pregnant, she can still use SSRIs safely. However, there is a risk for the fetus to develop neonatal abstinence syndrome once birthed, and then it should typically resolve within a few weeks. And this is important to note because she is of childbearing age. As far as the clonazepam risk concerned, there is a risk for abuse and physical dependence, and this should be monitored and addressed. The medication should not be used in combination with opioids or alcohol due to the risk for increased respiratory depression, which can be fatal. And this medication is being prescribed as an as-needed basis for her episodic panic attacks. And if she does require more frequent dosing or is using it more frequently, then the conversation should be had to switch drugs, so she doesn't become physically dependent on it. There is also a risk for to the fetus in utero, and this should be discussed, and contraception should be an option because using benzos while pregnant can cause harm to the fetus. Non-pharmacological interventions include cognitive behavioral therapy, meditation, relaxation techniques, and breath work. Monitoring parameters for SSRIs include weight, height, BMI, suicidality, psychosis, behavioral changes, and again, sodium in at-risk populations can go low. Monitoring for clonazepam includes mental alertness as it relates to the sedative properties, a CBC liver and renal function testing if using long-term, also suicidality or severe thoughts of depression or behavioral changes should be monitored as well. And Maria is referred to psychotherapy for cognitive behavioral therapy and EMDR therapy to process her trauma and hopefully potentially reduce her frequency in her panic attacks, or at least make her life more manageable, and as this relates to the suicide of her mother and her recent passing of her grandfather. And panic disorder can be effectively treated with SSRIs in combination with cognitive behavioral therapy, and therefore this is why that treatment plan was chosen.